right, welcome to today's Explainer, everyone. I am absolutely thrilled to be with you today. As future healthcare providers, you are going to encounter patients across the entire spectrum of childhood. And let's be honest, trying to memorize every single clinical milestone from birth all the way to graduation, it can feel completely overwhelming. It's like a giant puzzle. But that is exactly why we're here. My goal today is to take these really complex pediatric stages and transform them into a highly organized, super digestible clinical study guide. We're going to map out a crystal clear path through pediatric growth and development. Here is our syllabus for the session. 1. Growth versus development. 2. Infants and the baby stage. 3. Navigating the toddler years. 4. Preschoolers. 5. The school phase. And 6. The teen transition. Let's jump right in. Section 1, Growth versus Development. Before we get into the ages, we need to get our foundational vocabulary straight. You know, in everyday conversation, we tend to use growth and development like they're the exact same thing. But medically, they mean very different things. Grasping this distinction is absolutely crucial for your patient assessments. Let's start with growth. Growth is entirely quantitative. It's measurable, it's objective, it's physical. When we talk about growth, we're talking about body dimensions you can actually plot on a chart using centimeters, millimeters, or kilograms. For instance, when you document an infant gaining 2 kilograms in a single month, or maybe an X-ray shows a child's bones increasing in length, that is growth. Now, development, on the flip side, is a qualitative improvement. You can't just slap a tape measure on it or weight on a scale. Instead, you assess development through functional milestones. It's all about progression and maturation. When a toddler takes their very first unassisted steps, or when a child suddenly has the language skills to tell you a complex story, that's development. It's their motor, cognitive, emotional, and social capacities leveling up. So the real kicker here is the direct contrast. Growth is objective, and it actually has a finish line. It stops after maturity, right around the time our adult height stabilizes. But development? Development is a lifelong process of learning and adapting. Think about it. An adult might stop growing taller, but they are still developing better emotional regulation and complex problem-solving skills for their entire life. All right, moving on to Section 2, Infants. We call this the baby stage, covering birth to 1 year. I want you to literally burn this acronym into your memory. Babies. This is going to be your reliable mental framework. B is for body changes, like those fontanelles closing up. A is for achieving milestones. The second B reminds us of baby safety, which, trust me, is a massive part of parent education. I is for interventions, specifically remembering Erickson's trust versus mistrust stage. E outlines their eating plan, particularly the recommendation for exclusive breastfeeding for the first 6 months. And S stands for social stimulation, things like playing peekaboo to really foster that observation and interaction. Look at how fast this all happens. The physical growth and functional development map out together perfectly. At 2 months, an infant is tracking faces and smiling. By 4 months, they babble and roll over. By 6 months, and definitely take note of this clinical marker, they sit with support and they double their birth weight. By 8 to 9 months, they're crawling and mastering that crucial pincer grasp. And by 10 to 12 months, they're walking, saying simple words like mama, and they've literally tripled their birth weight. Seeing that physical growth align perfectly with functional skills gives you the complete clinical picture. Let's zoom in on that 4-month milestone of rolling over for a second. This connects directly back to the baby safety letter of our mnemonic. Sudden infant death syndrome, or SIDS, is a huge risk here. We have to educate caregivers to always place the infant on their back to sleep, keep that crib completely free of loose bedding, and eliminate any smoking exposure. Plus, once that infant achieves the developmental milestone of rolling over, you've got to instruct parents to stop swaddling immediately to prevent entrapment and suffocation. Section 3, Navigating the Toddler Years. We're looking at ages 1 to 3 now. To capture this slightly chaotic, wonderful stage, we use the 9-letter toddler acronym. T is for temper tantrums. O means they are on the move. These kids are everywhere, so safety risks shift to hazards like drowning and poisoning. D is diaper to potty transition. The second D is developmental theories. L is a big one, loves to say no. E is eating plan. They kind of become picky grazers at this age. R is ritualism. I mean, they need that same routine to reduce stress. The final two are rivalry with siblings and regression, where they might temporarily revert to baby behaviors when they're stressed out. As a clinician, you'll need to reassure exhausted parents that behaviors like negativism, just saying no to everything, are actually incredibly healthy tests of their developing independence. To really understand the why behind all that toddler behavior, we need to look at our major developmental theories side by side. According to Piaget, toddlers are moving from the sensory motor to the pre-operational stage. They are egocentric. They engage in what we call parallel play, meaning they'll happily play independently right next to each other but not actually with each other. Erikson, though, frames this stage as autonomy versus shame. Their entire emotional drive is just to do things themselves. So when you see a toddler having a total meltdown because they can't tie their shoe, that is Erikson's autonomy drive clashing hard with their physical limits. Positive reinforcement here is absolutely key. All right, Section 4. Preschoolers. This covers ages 3 to 5. Our mnemonic here is, conveniently, preschool. P is for physical changes. They're losing that baby fat and gaining real coordination. R is reduced separation anxiety. E covers Erikson's initiative versus guilt and Piaget's pre-operational stage. S is safety, because now they need bike helmets and swimming lessons. H is healthy eating. They're usually a bit less picky now. O is others in play. The second O is outline behavior expectations. L is for child fears. Magical thinking makes those monsters under the bed very, very real. And the final L is their language explosion. Actually, let's talk about that magical thinking for a second. This phrase brilliantly illustrates how preschoolers process language under Piaget's pre-operational stage. They are highly egocentric, literal thinkers. If you're in a stuffy clinic room and you casually say to a colleague, "Hey, can you crack the window?" a preschool patient might become absolutely terrified, thinking you are actually going to physically smash the glass. You have to be incredibly careful with your clinical phrasing. Choose your words literally and clearly. We also see a massive clinical shift in their social development here. Remember parallel play in toddlers, just observing each other independently? Well, preschoolers transition to associative and cooperative play. By age 3, they actually start sharing and coordinating. They might build a sandcastle together on the beach. And this isn't just fun and games. It's serious developmental work. It's teaching them teamwork, power dynamics, and shared leadership roles. Section 5 brings us to the school phase, ages 6 to 12. Let's unpack the school acronym. S is for mastering skills. Fine motor skills like writing, gross motor skills like riding a bike, and complex cognitive skills like math. C is for changes. They lose their baby teeth, and incredibly, the late stages of this phase see the very beginning of puberty. H is harmful risks. They need robust education on protective gear and traffic safety. O is obstacles, things like bullying and obesity. The second O is the outcome of hospitalization. Their biggest fears now are loss of independence and modesty concerns. And L is learn, developmental theories like Erikson's industry versus inferiority, where feeling competent is just about everything to them. Now, I want to highlight a highly specific, measurable benchmark for you, 2.5. This represents the average inches of height a school-age child reliably gains per year. From age 6 at roughly 45 inches up to age 12 at about 59 inches, this steady 2.5-inch annual growth rate is a vital benchmark you're going to be checking during your pediatric well-child visits. Finally, Section 6, Adolescence. The teen transition, spanning ages 13 to 18. To master this complex phase, we use the TEEN acronym. T stands for the massive changes of puberty, sexual maturation, secondary characteristics, and major emotional shifts driven by those hormones. E reminds us to look out for eating disorder signs, keeping a really watchful eye for anorexia and bulimia. The second E is for education, which shifts heavily towards safety, mental health, and media literacy. And N is the nurse's role. Your clinical focus as a provider must now shift heavily toward emotional support. You have to ensure extreme privacy, treat them as autonomous young adults, and provide honest communication without any judgment. Let's look a bit closer at that education component. Driving safety is the leading cause of death in adolescence. This is a crucial fact. It underscores perfectly why your role as a healthcare educator goes way beyond just biological changes and textbook medicine. Assessing suicide risk, looking for substance abuse, and really emphasizing seatbelts and safe driving habits. These are literal life-saving clinical interventions for the teen population. And that brings us to the end of our developmental journey. So, I want to leave you with this final vital question to reflect on. You now have the structured milestones, you have the mnemonics, and you know the theories. But, as future healthcare providers, how will you practically adapt your bedside communication style? How are you going to shift your approach from soothing the magical, literal mind of a preschooler who's terrified of a thermometer to successfully connecting with a privacy-seeking, autonomous adolescent who just needs you to be a trusted confidant? Mastering that transition? That is what will make you truly exceptional providers. Keep studying, keep asking great questions, and I will see you all in our next explainer.